Now we're moving into chapter 13, which is vital signs and monitoring devices. So we've covered the first two segments of the assessment process in the scene survey or the scene size up and the primary assessment. So now we've covered basically everything that occurs from the time of dispatch till the time you get on scene, and then everything that occurs as you walk into the scene in that first few seconds, basically. Now, the next couple sections that we're going to move into, a lot of these processes are going to occur concurrently with each other. So you're going to maybe be doing some of your general assessment that you'll learn in the Principles of Assessment chapter while you're also taking your vital signs. So now we're starting to move into some areas that are going to overlay each other. Vital signs and these monitoring devices, very important in the assessment process. It's going to give you a baseline, so it's going to give you that initial reading as to where the patient stands, whether that's normal or not normal. But it's going to set that benchmark for either you want the patient to try to get back to normal while they're in your care, or you want to maintain them in normal, but you're monitoring for them to look outside of that normal range. And then it's going to give you a lot of indicators as far as your treatment, what might be going on with the patient. A lot of times the vital signs will mirror up with what the patient's chief complaint is, and you can kind of start plugging all the numbers together to figure out what's going on with the patient. So important chapter. It's a long PowerPoint. I'm going to try to cruise through it fairly quickly because honestly this is going to be the better hands-on section. All of this stuff will actually do hands-on. So whereas in the PowerPoint it's going to kind of go through step by step, we'll explain it all, but then the hands-on will actually be probably the better place where you're going to get exposure to this. So as we look at the gathering of these vital signs and kind of where they fit in, part of it's going to depend on that primary survey that you do on the patient, because like we talked about, the first thing is always the life-threatening conditions. So if the patient doesn't have a pulse, no signs of life, and you start CPR, that kind of comes to the forefront over obtaining vital signs initially. So you want to make sure to basically take care of any of those immediate life threats. And then as we move into the assessment process and the secondary assessment process, we're going to obtain these vital signs. Like I said, a lot of this is going to be done concurrently with other parts of the assessment, and you'll discover your own little method of how you do things. For example, you may walk up to the patient, start asking them a couple questions about what's going on, at the same time tell them you're going to check their pulse. So while you're asking them some questions, you're feeling for their pulse, trying to get a rate out of it, and feeling for, is it strong, is it weak, is it regular, is it irregular, everything that goes along with it. So a lot of this stuff is concurrent. The vast majority of patients will have vital sign measurements. At some point during the transport, you're going to want to get the vital signs. It may not be initially, it may not even be until after you get them in the ambulance, depending on how critical your patient is. But it is important because it helps you understand the conditions that are going on with the patient, and it also lets you understand if the patient's trending certain directions. So if you take a blood pressure and it starts out a little bit low, and then 5 minutes later you check it and it's a little bit lower, and 5 minutes later you check it again and it's a little bit lower, and it keeps going downward, then you should understand that there's probably something more serious going on that needs to be taken care of. So you're looking for these trends that go with it, but you're going to take these vital signs initially, and that's going to be called the baseline. It'll talk about that later. And then you'll repeat them while you have the patient, depending on the severity of the patient. Generally speaking, you want every 5 minutes if they're critical, every 10 minutes if they're not critical, but it never hurts to do vital signs. So even if they're not critical and you're doing it a little bit less than that 10-minute mark, that's perfectly fine too. So just understand that it is very vital part of the assessment process is getting these vital signs. Now, what are vital signs exactly? Well, basically, they are what you see on the outside to try to help determine what's going on the inside of the body. So that's the outward signs of what's going on inside the body. They're kind of a handful of pretty standard vital signs that you need to get on every patient, being the pulse, the respiration, and then you're going to assess the skin with color, temperature, condition. In infants and children, it's important to measure that cap refill. And then on all patients, you also want to measure the pupils and the blood pressure. Oxygen saturation, which is SpO2, and it'll talk about it later in the chapter, is one of those that it's kind of just thrown in there with vital signs. It's not often included with the consideration of the vital signs, but pretty much every ambulance has the ability to measure it, and it's one of those things that you're not doing anything to the patient by measuring it negatively, so why not just go ahead and measure it? And then there are some other vital signs that they'll talk about in here that are fairly important too, like blood glucose readings. But basically, the chapter is going to go through each of these vital signs, how to obtain them, what they mean, what you're looking for in them, so that you can understand the assessment process a little bit better. Like we mentioned before, that first set of vital signs is going to be your baseline. Hopefully, in a perfect world, your patient's going to have vital signs that fall within normal ranges or pretty close to normal ranges. But more times than not, if they call the ambulance, they are going to have probably at least one, if not more, vital signs that are abnormal. And then what you're using is that first one kind of as your benchmark, like we talked about. And then as you gather new vital signs, you need to take into consideration what that baseline vital sign was to determine, are things changing for the better, are things changing for the worse. It'll help you kind of gather information as to the condition of the patient, and should you change your treatment process at all with the patient. So it is important to continuously get these vital signs throughout the call. Like we said, it's going to depend on that patient condition. First vital sign here is going to be the pulse, and that's going to be the easiest one to just, when you walk up to the patient, let them know, hey, I'm going to check your pulse while we're talking here, because it's going to give you more indicators than just what the pulse rate is, and I'll talk about it like when we get to the blood pressure, how the pulse kind of clues you in with the blood pressure, and it's going to just give you a lot of indication as to what's going on. But the pulse is the palpable pressure of the heart beating, causing blood to move through the arteries in waves. So basically, every time that your heart beats, as you're palpating that pulse, you're going to feel a little thump, thump, thump. You count those thumps, and then that gives you what the pulse rate is. So for an adult, our normal pulse rates are 60 to 100. So 60 beats per minute to 100 beats per minute is normal. Now, slightly below, slightly above doesn't mean that something's necessarily wrong. A lot of times you'll find marathon runners will have a pulse rate pretty consistently in the 50s, because their body's been trained, and that's what their heart knows. When they're at rest, that's the rate that is completely normal for them. Now, when you look at younger age kids, so really basically 10 and under, the pulse rate starts changing as to what their normal is. And it's going to basically increase a little bit the younger they get. So a brand newborn baby, 100 to 170 is going to be the normal, and then it starts lowering as that child progresses through age until they reach about age 11, and that's when you should start seeing that normal range fall into the 60 to 100. If you take your fingertips and place them over an artery, and we'll talk about a few different spots that you can check for a pulse, basically you're going to feel that thump, 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 and that's what the pulse is. So basically you're pinching off that artery, not completely, but you're pressing it against a bone or another structure inside the body so that you can palpate those thumps. So just had a call mid-lecture here, so I'm going to try to pick up where we left off. But we were talking about pulse, and the two things we're looking for with pulse are going to be the rate and the quality. Rate meaning, is it fast or is it slow? I talked already about those normal ranges of 60 to 100. So significantly below 60, abnormal, significantly above 100, abnormal in your normal adult or adolescent kid. And then the quality it's going to talk about here, but is it strong, is it weak, just some of the variables that go along with what it feels like when you're actually palpating for that pulse. And here's what it kind of looks like when you're checking a pulse. They're checking the radial pulse here. So you're going to run those 3 fingers over the inside of the wrist and then kind of gently push down. You don't want to pinch off the actual artery because then you won't feel the pulse. You'd basically be functioning as a tourniquet at that point, but you want to put enough pressure on it that you do feel that thump, thump, thump. You're going to be counting for 30 seconds, multiply that number by 2. If something's super abnormal, you may want to do it for a full minute, and then if something's completely run-of-the-mill, you can also just go for 15 seconds and multiply it by 4. Best practice is to go at least 30, multiply it by 2. It's going to give you a little bit more accurate number, but you want to get that rate, and then your feeling, and this is kind of subjective here, because it's your opinion on what you feel, and everybody kind of has different thoughts when it comes to everything in the assessment process. So you have to use your best judgment in what that pulse actually feels like. So this image shows you them checking the radial pulse, which, like I said, is the inside of the wrist. The other common spots, and I'll talk about these here, are going to be the brachial pulse, which is going to be on the inside of the upper arm, most commonly checked with kids, but we also utilize that pulse when we're checking blood pressures. And then your critical patients, when you really need to know if they have a pulse, you're checking the carotid artery, which again is just feel the top of the trachea, slide over towards whatever side you're on into the little notch there, and palpate, and you'll feel that pulse there. The other place that can be checked for a pulse is the femoral pulse, which is going to be kind of in that notch between your groin and your leg. It can be a little bit more challenging to locate, something you'll definitely want to practice, probably on yourself, so that you can kind of get a feel of where that's at, but you can usually feel a pretty strong pulse there as well. And then anytime you have an injury to an extremity, you want to make sure that you're checking the pulses. So there are pedal pulses, pulses in the ankle that you might have to check depending on the situation, but we'll learn about a lot of those later when we get into the trauma sections. A couple slides here talking about pulse rate. So we're measuring again that number of beats per minute. Normal for an adult 60 to 100, ranges upward for pediatric and infants, neonates. Basically, the younger you are, you can expect a little bit higher normal, and you can look through the book and kind of see what those normals are. You'll want to learn those. They'll emphasize them a little bit more as we get to each individual chapter. Now, tachycardia, bradycardia, if you think back to our medical terminology, now we're breaking down the cardia being the heart, tachy meaning fast, brady meaning slow. So anything over 100 is going to be considered tachycardic. Anything below 60 is going to be considered bradycardic. So now you're kind of seeing how piecing sections of the chapters that you've already learned and kind of how they play into what you're currently learning, and then that's just going to keep growing as we move through the book. A little bit more here on the pulse rate. So above 150 beats per minute, or really above 120 beats or below 50 beats per minute across several measurements is considered a serious finding. So if you initially check them and they're above 150, it should raise a red flag. If they're at 135, not so much a red flag unless they stay at 135 for a period of time. Just remember, like, if you've never been in an ambulance or you've never been sick to where you've had to call an ambulance, your anxiety level is going to be up, your adrenaline's going to be going depending on the situation. So it's not abnormal to see an elevated heart rate, but with time it should work its way back into the normal range. If it doesn't within that period of several minutes, then it may want to raise a red flag for you. There's obviously a lot to it, but that when you look at the pulse, that is kind of the indicator with it. Like I said, it's not unusual for patients to be between 100 and 140 beats per minute. Usually they're not abnormally low. If they're down below 50 regularly, that would probably raise a red flag. But if they're a little bit elevated, it's kind of to be expected just because of the nature of the environment that you're putting them in, and everything that's going on with the anxiety level. So a couple more things there to keep in mind with the pulse rate. So just thinking here, let's say you roll up on a call, you find a patient with a heart rate that's outside of the normal range. We'll say it's elevated. Um, what would be some normal situations that you might think about? Things off the top of my head are activities, sports types activities, or if it's a football player that just got injured and they've been exerting out on the field, probably pretty normal that they're going to have an elevated heart rate. Just think of any cardio workout you do. What's the goal of cardio workout? Goal is to raise that heart rate. So in those situations where maybe you end up with a patient that is in that mode, you kind of have to use, I'll say, some common sense to put two and two together and figure out, all right, they're outside of the normal, but is there a reason they're outside of the normal? Hopefully that makes sense, but just kind of process it and think about some situations that you might run into. The first factor with the pulse quality is going to be the rhythm. So that's the regularity. So when you're feeling it, if you're feeling a pulse, say every couple seconds, is that interval between the pulses staying the same? You'll be able to tell it once you feel an abnormal pulse. It'll kind of bounce, 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 versus a very regular thump, 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 thump. That's what you're looking for when it comes to regularity. If it's irregular, you want to make a note of that. At the basic level, you're not going to be able to really look at cardiac rhythms, but there are a few different circumstances that cause that pulse to be irregular. Some of them can be completely benign, but many times it could be indicative of maybe a serious medical condition. So that regularity is kind of an important factor to take into consideration when you're feeling that pulse. As far as quality goes, the two factors you're looking for here is first going to be the force. So that's the pressure of the pulse wave as it expands the artery. So as you're holding your 2-3 fingers down on that pulse, every time the heart beats, it sends a little bit more pressure through, which expands that artery, and you're feeling that artery expand. So what you're looking for is it should be a fairly strong thump as you're feeling it. If it feels like it's about to pound out of the skin, that's abnormally strong. We would call that a bounding pulse. And then vice versa, if the pulse feels weak and thin, like you're having a hard time even feeling the pulse, then we call that thready. So those are kind of the two things as far as the force go. All right, so back to these pulse locations. So the radial pulse is going to be the most common place that you're going to reach for checking a pulse, and it's really going to be for any of those patients that are a year or older. When you get younger than a year, the anatomy is just so small and fragile that it's really kind of hard to feel a radial pulse on an infant that small. You'll move to the brachial pulse, which we'll talk about in the next slide. So anybody that's a year or older, we're checking the radial pulse. Now the radial pulse, if you think about back to the anatomy chapter and the radial bone in your arm, you're basically pushing that artery up against that bone to feel that thump, thump, thump. You're going to place 3 fingers. If you go on the thumb side of the wrist, on the underside, you'll kind of follow the wrist bone around into a little notch between that bone and the tendon that runs up the underside of your wrist. When you slide your fingers into that notch, you should start feeling that thump, thump, thump. If you don't, just kind of readjust until you do find it. Honestly, the best thing to do is practice. Practice on family members, practice on friends, practice on anybody that'll let you grab their wrist to check a pulse, so that you can learn it and understand it. The more you do all of these skills, the easier they're going to get. So expose yourself as much as you can. Brachial pulse, commonly used on patients under the age of year 1. It's going to be in the upper arm, just above the elbow on the inner side. You're kind of reaching just underneath the bicep and pressing it against the upper arm bone and the humerus, and you're going to feel that brachial pulse. It's pretty easily found in infants, but again, if you have access to a baby, practice it. The next slide here is going to show you kind of visual of how that works. And then again, to reiterate here, the carotid, again, going to be the go-to spot on those critical patients when you want to see if they have a pulse or don't have a pulse before you start CPR. It's kind of just the go-to area because it's going to be the last pulse that fails. So you may have a patient that doesn't have a radial pulse, but they may have a carotid pulse, and we'll talk about that when we get to the blood pressures as well. But basically, run your fingers across the trachea and then slide them towards you into that notch just next to the trachea, and then you should start feeling the thump, thump, thump. Practice this on yourself. Don't pinch off both carotid arteries when you're checking for pulses. That would be counterproductive. But again, just the more you practice this, the better you'll get. And the last slide here on pulse quality is going to be just kind of reiterating a little bit. 30 seconds, multiply it by 2. When in doubt, you can always run it for 60 seconds, and then that gives you a true pulse rate per minute. Rate, rhythm, and force is not normal, is when you're going to want to continue for that full 60 seconds. Again, it's very subjective as far as what you're feeling. You may check a pulse and then have your partner check a pulse, and you may feel things a little bit differently based on how you've learned the material and kind of what your mindset is for what a bounding pulse is, what a weak thready pulse is. Part of it is just practice. You may be experienced at checking pulses and feel comfortable in making that assessment, and maybe your partner is new and doesn't fully understand what they're feeling for, so they may have a little bit different interpretation. But ultimately, as the EMT and as the provider, it's going to be up to you to make that determination. All right, moving on to respiration here. With regards to vital signs, respiration is the act of breathing in and out. So one respiration is one breath in and out. So you're counting how many times they take a breath in. That would be their total respiration. Similarly to the pulse, what we're looking for here is rate and quality, and abnormalities from what the normal levels are. Looks like Limmer has failed in their editing of the book, because if you read the picture down below, it says assess respiration, rate, and quality. Again, you're going to similarly to a pulse, count for 30 seconds and multiply it by 2. However, the image shows you a guy checking for a radial pulse, so kind of disregard what the image is, but just understand it's the same concept, whether it's respiration or pulse. 30 seconds, multiply it by 2. For the quality, there are 4 different categories we're looking for. Normal, which any of you should be able to kind of assess your own breathing and understand what normal is based on how you feel. Shallow, which means you kind of have to look close to see if they're breathing. They're kind of short breaths where it doesn't look like they're taking in a whole lot of air when they breathe. That would be considered shallow. Labored breathing is when they're working excessively hard to breathe. And you'll be able to note some of these just by watching them. And are they using accessory muscles? Are they in the tripod position that we talked about previous chapter? You'll be able to utilize some of your assessment skills that you've learned elsewhere, determine if it's labored. And then noisy breathing is anytime you hear abnormal noises. There's a couple different abnormal noises that we'll talk about when we get into the airway chapter with lung sounds. But if there's any abnormal noises, then it's considered noisy quality. For the respiration rhythm, first, and it should go without saying, but a little bit of a reminder here, if there's something abnormal in their respirations in an unconscious patient, you need to report it, you need to document all your findings. It's going to be this way with anything that you see that's abnormal, but you want to count the respirations after you assess the pulse rate. Kind of the reason being is you can't see a pulse rate, you have to feel for the pulse rate, but you can visually see respirations occurring. So while you're checking the pulse, you are able to see their chest rise and fall. You're going to understand that they're breathing, and then you can do a further assessment once you get the pulse taken care of. Similarly to the pulse, 30 seconds, multiply it by 2. We're looking for rate, quality, and rhythm with that. All right, next important piece of this assessment process that we're learning about here is the skin itself, and how do we evaluate the skin. So what we're looking for is color, temperature, and the condition of the skin, because that provides you valuable information regarding circulation. As we go through the chapters and really as you gain experience, you're going to learn things like a cardiac patient will commonly have pale skin in the beginning, maybe gray if it's a more serious cardiac event, and they're usually going to start out either diaphoretic or sweaty, or sometimes cool and clammy. Basically, the skin shows you how the body's trying to compensate for another issue that's going on in the body. So it is a good assessment tool to utilize for just a very quick, all right, there's something going on because this is abnormal. So where's the best place to assess for the skin? You don't just look at their face or their hands or wherever, because you might see some abnormalities that aren't indicative of what is truly going on. You want to look someplace, like if you look at your nail beds right now, they should be pink, very pink. That's the normal color that you want to see. Another good place to look is the inside of the cheek, or inside, if you kind of pull the lower eyelid away from the eye, you'll be able to get a good visual of what the color should look like there. In infants and children, you can also look at their palms and the soles of their feet. It does get a little bit more tricky with certain ethnicities in patients, so African Americans or dark Hispanics, it's a little bit harder to assess the skin color. So again, utilize the lips, the nail beds. Nail beds are kind of always the go-to when it comes to assessing. What you want to see, what the goal is to see that nice pink color. That's what you'll find in a healthy person. If you start seeing some abnormal colors such as pale, which is just kind of a lighter pink or white looking color, that's abnormal. Cyanotic, which would be considered blue or gray. Flushed would be kind of a red color, and then jaundiced will show you a yellow color. Jaundice especially, you can see that very easily in the whites of their eyes. If you can look there, common to see in babies, and you'll also see that in patients with liver issues. That's where you'll start seeing the yellow. But these abnormal colors are what you're looking for, and then based on other complaints and other assessment findings, you should be able to start narrowing down what's going on with the patient. The best way to get temperature is obviously going to be to use a device to get that temperature, which we'll talk about, but you can kind of get a quick feel. Use the back of your hand, not through the glove. Make sure you pull the glove down enough that you can get your skin against their skin. What you're feeling for, is it normal? Is it hot? Is it cool? Or is it cold? Again, with experience, a lot of this stuff will become easier the more you expose yourself to different techniques. The easier this assessment is going to become. And then kind of a sidebar here, but for children under the age of 6, what you want to do is utilize another tool called capillary refill. So if you, it's either on their nail bed, or if they're a small enough kid, you can use the top of their hand or their foot. But basically, you're going to hold down for a few seconds and you're going to let go. It should be white in color initially when you let go, and it should return back to normal in less than 2 seconds. If it takes longer than 2 seconds, it means that the body's not perfusing properly. And again, it's a really good tool in kids under the age of 6 to utilize. Onward to pupils, and it's kind of the gateway to the brain. The pupils are. The pupil is that black center of your eye, that dot right in the middle of your eye. If it's a dim environment, so if you turn the lights down, that pupil is going to dilate, which means it's going to get bigger. And then once you put light over it, the pupil should constrict down and become smaller. If it's a normal pupil, that's the response that you're going to see. A bigger pupil in dark environment, and then a smaller pupil in a bright environment. What we're looking for here is size. Most pin lights, and we'll show you when we do the hands-on, it'll have a little size, but you're measuring it in millimeters. You want to make note of that. You want to make note, is the left eye and the right eye equal? Do they respond the same? And then you want to make note of reactivity. So you want to put them in a darker environment, shine the light in on them, and I'll talk a little bit more about that in a couple more slides. But that light should constrict down, and then when you pull the light away, it should dilate back out. That's what you want to see. That's what the normal is. So as far as actually assessing it, now don't use like a light source that's going to be like the surface of the sun, because that's going to skew your findings a little bit. But use, they make little pen lights specifically for it. You can use a flashlight that's not ultra bright. And what you're going to do is you're going to cover up one eye. You're going to run that light. You're going to turn the lights down, and then you're going to take your light source and then run it from outside of the face over into the eye to see if it reacts. And then you're going to move that light source back off of the eye and then back in over that eye one more time to confirm. And then you want to switch eyes, do the same thing with the other eye. So cover up your first eye, run that light source from off of the face into the eye, see what it does, move it back out, and then back in again, and it should do the same thing. And the eyes should react the same way from the left side to the right side. And this is just a quick visual here to show you kind of what we talked about there. So he's running that light source over the eye and then back off. And then if you look close, you can kind of see those dots on that little pen light. Those are going to indicate what size it is. So you can kind of compare what you see in the eye to that size on that little pen light, and it'll give you a measurement that you can utilize and mark down as your baseline. And then from an assessment standpoint, these are kind of the three different things that you'll see with the eyes. Constricted eyes, so it's when that black is smaller. Dilated eyes, when it's bigger. And then unequal pupils. So one size might be big, one size might be small. Very obvious when you see this in the assessment. Can be a number of factors. Usually they're not good factors. But you want to make note of things like, okay, I shine the light source over and the pupils didn't react, or without a light source the pupils were already constricted, or what we call pinpoint. Like I said, there's a number of things from drug use to brain injuries that cause this. And then last little slide here on the assessment, and this shows you a visual of what unequal pupils would look like. And it, like I said, it could be something as simple as eye drops that they put in there that caused it. If it's some sort of trauma that the patient's been involved in and you see this, usually a big red flag. Like I said, the pupils are kind of the gateway to the brain. So if you see unequal eyes in a trauma patient, it can be indicative of a brain injury. So kind of turns your assessment process then a little bit and your treatment process, and maybe should have you thinking things could be a little bit more serious than what they appear. Moving on to blood pressures, and blood pressures are probably going to be the most challenging skill to learn from everything in this chapter. It's just a technique that takes a lot of practice to be good at. People rely entirely too much on machines to give them the blood pressure. The first blood pressure truly is best to always take where you're listening to it, because you know 100% it's accurate. Machines are good then once you have that baseline established to compare and know kind of where the changes are, because then it frees up your hands and it's something you don't have to do. But there's nothing wrong with continuing to do blood pressures the old-fashioned way with a stethoscope. So as we look at a blood pressure, what it's measuring is the force of blood against the walls of the blood vessels. There are two numbers we're looking at. If you've ever been to the doctor and they check your blood pressure, you're going to have a high number and a low number. That systolic pressure is created when the heart contracts. So when that heart squeezes down and forces blood into the arteries, that's going to give you that high number. The low number is the diastolic pressure, which is what remains in the arteries when that left ventricle, which squeezes the blood through the body, relaxes and refills. So you're looking for two numbers when you're auscultating for a blood pressure. Normal, and I use this term loosely because everybody has a different normal, but the textbook says normal is the systolic pressure being no greater than 120 and the diastolic pressure being no greater than 80. This has changed a lot over the years, but right now the numbers are 120 over 80. Like we said, change in that can be something very significant. If you see numbers that are extremely high, that's very abnormal and can cause some very serious conditions. And if you see numbers that are entirely too low, the same is true. Can be very serious conditions, and usually the blood is not perfusing through the body like it should, and then you have to be worried about further complications because of that. Term of the day here, blood pressure is measured with a sphygmomanometer and a stethoscope. If you don't want to get used to using the word sphygmomanometer, we call it a blood pressure cuff. So it's that cuff that's Velcro that wraps around your upper arm. It's going to cover the upper 2/3 of the arm, basically about an inch above the elbow, and then you're going to utilize that, and it's going to go through a few slides here explaining how to measure. The one thing to remember is using the proper size. You don't want to use a blood pressure cuff that's too small. It'll give you an abnormal high reading. You also don't want to use a blood pressure cuff that's too big. It'll give you an abnormal low reading sometimes. So keep that in mind when you're checking blood pressures. It's going to talk about blood pressures. The standard is that upper arm. There are circumstances where you can check it in the lower arm. They also make thigh cuffs where you can utilize it to check in the thigh. A little bit more tricky there, but 99.99% of the time, our blood pressure cuffs going on the upper arm just above the elbow. So we're going to measure this blood pressure with the blood pressure cuff. Like we talked about, above the patient's upper arm. You want that lower edge of the cuff to be about an inch above the crease of the elbow. That's going to leave you space where you're going to end up putting that blood pressure cuff. And then the center of the bladder needs to be over the brachial artery. On most blood pressure cuffs, what you're going to find is a label with two arrows, and then you want your brachial artery to fall in between those two arrows. When you put it on there, again, get it on there tight, but once you start squeezing the bulb to inflate that cuff, it's going to tighten up to the arm. So you just want it tight enough to kind of maintain its position as you're getting things ready. So first and foremost, prepare the patient. Again, don't do anything without patient's approval. If you physically touch the patient and they didn't want you to,
It could be considered assault, so make sure you're explaining to the patient as you're doing things what you're doing, and then you want to get that blood pressure cuff into position. Um, as you're learning this, you can palpate where that brachial artery is at the crease. After you've done it a while, it's pretty standard in the same spot on all people, but you want to get that blood pressure cuff lined up in the right spot. Once you get the blood pressure cuff on, you're going to take the head of the stethoscope, you're going to put it over that brachial artery, um, just kind of above the crease of the elbow, on the inner side, if that makes sense to you, or the medial anterior elbow, is what you're looking for. So there are actually two ways to do this. One is with the stethoscope, which is the common way. But if you're having a hard time hearing it, you can also just get that systolic or the top number with palpation. So you'll pump up the blood pressure cuff after you've found that brachial pulse. Once you get your fingers in place where that brachial pulse is, as you're pumping up the cuff, it'll disappear. Once it disappears, go up by another 10 or 20 on the gauge, and then stop and slowly let the air out. When you start feeling the pulse again, that's going to be your systolic pressure. So by palpation, that's what you're looking for, is that top number when you start feeling the pulse again. Now, with the auscultation, when you have that stethoscope over the brachial pulse, basically what you're going to do is you're going to start pumping it up, and you're going to pump it up to probably 160 to 180 on the gauge to start. Once you get up to there, you should have your stethoscope in place over the brachial pulse. You're going to slowly disengage the, the knob on the bulb, and that'll slowly let air remove out of the cuff. When you hear the first thump, that is going to be your systolic pressure. Um, but it's one of those things, the more you do it, the better you're going to get. So when you first start doing it, really let that air release slowly from the cuff, so that you can make sure that you hear that first thump. As you get experienced and you do it more, you'll be able to do this process fairly rapidly. But in the beginning, until you get some confidence, that's what I would say. Just go nice and slow. Uh, Now the diastolic pressure, um, you're going to get, you keep letting the air out. So you've inflated the cuff, you're slowly letting the air out, you hear that first thump. That's your systolic pressure, the first number. Continue to slowly let the air go out until those thumps disappear. Um, when the thump becomes real muffled, and more or less disappears, that's your diastolic number. That's going to be the bottom number. You want to make note of both the top and the bottom and record those. So if your top number is, say, 124, and then you're listening and it stops at 80, your blood pressure is going to be 124 over 80. I already talked a little bit about the palpation, but um, you can do it by utilizing the radial pulse. So you put that blood pressure cuff on, you find that radial pulse, you pump it up, slowly let the air out. When you start feeling the thump as the air is releasing, that's going to give you the systolic pressure. If you do it by the method of palpation, then it's going to simply be 124 over palp, because you don't know what the bottom number is. The top number really gives you a lot of information, um, so it's better than nothing. But you want to just make a note of what that top number is, and then it's going to be that number by palp. So as far as peds go, any child younger than the age of 3, it can be challenging to get a blood pressure. Now there are circumstances where maybe you need to or want to, um, and it's okay if you do. Just understand it's going to be a little bit more difficult to obtain. Truly, your best measurement with pediatric patients is what you see. What's their skin look like? What's their respiratory status? What's their level of consciousness? What's their cap refill? You want to utilize all these tools. They can give you just about as much information as blood pressure when it comes to pediatric patients. And then just a quick slide here. If you're using a blood pressure monitor, position the cuff. Usually there's going to be a button that you push. On our cardiac monitors, it's called NIBP. Um, you push that button, and then it's going to measure everything on its own. It's got sensors inside of the cuff that's going to measure and feel that first thump, and then it's going to feel when the thumps stop, and then it's going to put a reading up on the screen for you that'll usually give you the systolic over the diastolic. Again, make a note of that. Best practice is always to utilize manual auscultation, blood pressure first, so that you have a good baseline. And then as you move forward, unless it's abnormal, you can utilize these blood pressure monitoring devices. Okay, on to temperature. And as you know, with COVID these days, temperature's kind of become an important assessment tool because it does tell you what's going on inside the body. And we know with COVID that low-grade fever and even a high temp is pretty common. So it's a good tool if they're having flu-like symptoms. Measure that. It may indicate a little bit more as far as that range goes. But really, the temp it's a very narrow range within the body. The core temperature reflects that level of heat inside the trunk of the body. So if you want to measure a true core temp, the only way to do it is rectally. That's going to be the best temperature that you can get. If you have a hypothermic patient, you might have to do it that way. 99% of the time, you'll be able to just do an oral thermometer and get a reading that way. But we'll talk about a couple of those devices here coming up. It is important to understand that that temperature range, although it is a very narrow range, it can fluctuate a little bit throughout the day depending on what your activity level is, what your age is, where you measure it. Like I said, the core temperature rectally is going to give you the truest body temperature. Oral temperature is going to be closely behind. But if you measure a temperature axillary, which is going to be under the arm, it's usually going to be a little bit lower than what the actual temperature is. Not to say it's not a good tool to utilize, but just understand that it's going to cause that normal temperature to fluctuate a little bit. So there are variables with this. Again, common sense goes a long ways, and just understand that you have to use all of the tools of the assessment to determine how significant your patient's illness is. Here's a quick image of them showing you an electronic thermometer, which is what we'll have at class, and show you how that works. This is probably the best tool. There's also infrared thermometers out there now where it just shoots that beam of light on the patient's forehead. They're better than nothing. They're not as accurate as these oral thermometers are. And then, like I said, at a quick assessment earlier in the chapter, we talked about using the back of your hand. You can usually gauge if a patient's warmer than normal or cooler than normal that way, but it's not going to give you a true reading. At some point in the assessment process, you do want to make sure to get a thermometer out and measure what that temp is. It used to be that we didn't measure temps all that often in an ambulance, but anymore they've determined that it really does clue you in a lot on things from COVID to sepsis that we'll learn about as we go through the book. And it has become a pretty good tool in the assessment process. All right, on to some other monitoring devices that are commonly used in the EMS world. The first one is going to be the oxygen saturation. So this is going to be a percentage that you're measuring of oxygen traveling through the blood. Obviously, 100% is going to be the best that you can do, but you can gauge a lot of what's going on with the patient based on this, as long as you're getting an accurate reading, and we'll talk about that. But it's the amount of oxygen present in the blood to the amount that could be carried. It's measured with a device called a pulse oximeter. Most commonly, it's going to be a little alligator clip that you put on the end of your finger. That's going to measure that. There's also sensors that hook to foreheads and the earlobes. You can always use these finger monitors on pediatric and infants' toes. You'll usually get a pretty accurate reading there as well. So it just depends what you have. You need to familiarize yourself with the equipment you have. Again, a good tool that you can utilize.
Picture just showing you the common pulse ox measuring device. Usually the pulse ox will also measure the heart rate at the same time. So it'll indicate the percent SpO2 that you can see on the top of that monitor is at 98%. So very normal. And the pulse right below that, you can see it with the heart, and then little parentheses next to it. This patient's pulse rate is running 82. So good device that'll give you some accurate information. Always work within your protocols when it comes to these extra devices that you may have. Pulse oxes are very common in the COVID era. You'll even find a lot of people that have pulse oxes in their house that they've been given because they've had COVID, and the doctors want them to regularly measure what their oxygen level is, because that's one of the early indicators that something more serious could be going on. Generally, what we're looking for is that number up around 100. As it gets lower, it's going to indicate possible different levels of hypoxia through the body. So it's going to be indicate basically some respiratory problems that you could have going on. So as far as measuring the pulse ox, normal reading is going to be 96% to 100%. So above 96 is completely normal. Mild hypoxia, 91 to 95. People can walk around 91 to 95 all day and you'll never notice anything. If they get down below 90, usually you'll start seeing some shortness of breath unless they have other medical conditions that might make them run that as a normal. COPD patients, the patients with emphysema and chronic asthma, they may run in the upper 80s and that may be their normal. Significant hypoxia will usually occur below 85. Basically, if you have a patient that has some sort of respiratory history, see what their normal levels are, because you want to maintain around their normal levels. If their normal levels running 90 to 92, then it's okay for you in an ambulance to try to maintain that level around 90 to 92. This will come into play a little bit more with a couple of the other chapters, the respiratory chapter, and probably the airway chapter when we start talking about oxygen administration. You'll utilize some of these numbers to determine what kind of oxygen that you should give the patient. So like I said, the pulse ox is usually accurate. However, there are some things that can cause inaccuracies in it. If the patient's in shock and they're not perfusing to their extremities like they should, or if they're hyperthermic and they're not perfusing to their extremities like they should, you're not going to get a true reading. Another one is any patient that's had CO exposure and they might have carbon monoxide poisoning going on. That number can be skewed because of the way the poisoning works within the body. So if they've been exposed, you need to measure really what their carbon monoxide levels are, more so than what their pulse ox is, because they could have a significant respiratory issue going on and still be measuring 100%. That's not abnormal in those situations. It's a beam of light that comes out of that sensor, so if the patient's moving around and jostling that, you might not get an accurate reading. If the patient's wearing especially those acrylic fingernails, that's going to affect the reading. And then really any medical condition that affects the blood flow to the extremities is going to skew what that number is going to be, to the point where you might not even get a reading. And it's not unheard of that happens. Try to adjust. When it fails, though, look at your patient. You can always do the visual check. If they're pink, warm, and dry, and they're not in respiratory distress, don't put a ton of stock in an abnormally low or no reading at all on the pulse ox. It just really depends on some variables. Next device here we'll talk about is the blood glucose monitor. Remember, glucose is the fuel to the body, and so what this is going to do is measure the amount of glucose in the bloodstream. Commonly, we use it in diabetic emergencies, but honestly, we check blood glucoses on just about every patient, because it's one of those things that you might find something that could indicate
some sort of medical conditions, and it's not an obscenely painful process to check it on your patient. So it is very commonly performed on patients. As long as your protocols allow, which most do, you'll carry a glucometer. And basically what you're going to need is this equipment. So the device in the lower left is going to be the actual glucose meter. Right above that is going to be the test strips. Those test strips will pop into that little notch at the bottom of the meter. And then from there, you'll basically draw some blood into the test strip. On the far right side is going to be, they're called lancets. You're going to pop that blue tab out of the end of the white, and then when you depress the blue on the other end, it'll kind of rapid fire a small needle. You can do this really any place that you can draw blood out of the body. Commonly it's on the fingertips or on the palm of the hand. One recommendation I would say is avoid where the patient would touch, because that's going to be the most sensitive area. Kind of get over on the side of the finger, or a lot of people are doing it kind of on the palm of the hand. Just any place you can squeeze out a few drops of blood to put it in that machine. There's also, shows a picture here of an alcohol prep. It's very important to clean the area first. You don't want to introduce any bacteria into the body, and vice versa. You don't want that blood coming out contaminated. That might skew what your reading is. Again, this is one of those things that's got to be in your protocols. You need to get permission from your medical direction to be able to utilize this device. Very commonly it is used. These monitors do require a little bit of maintenance in the fact that they need to be calibrated. It's nothing that you can really calibrate, but there are ways that you can verify that the monitor is reading accurately with test solutions. Usually you have to log those test solution numbers. And there is a separate licensure that the service would have to carry in order to utilize the blood glucose monitor, called a CLIA license. Again, not something that you need to be overly concerned about as an EMS provider, other than knowing there are a few rules and regulations when it comes to actually having a blood glucose meter and using a blood glucose meter. Commonly patients will have their own blood glucose meters, especially if they're diabetic. If they said they just check their blood sugar, you can use their number. Best practice is to always perform it with your own equipment. If nothing else, it'll verify that their number was accurate, and it gives you that true good baseline moving forward. So kind of repetitive here, but again, you're going to prepare that device. You're going to insert the test strip into the device, and you're going to have that lancet ready. You're going to clean the patient's finger with the alcohol prep. You're going to perform the finger stick. And then there's a little notch in the end of that test strip. If you run that test strip inside of the device, it needs to be in the device when you do this, and you kind of bump it right up to the blood, it'll actually more or less suck that blood into the test strip. And then depending on your equipment, it usually only takes a few seconds to analyze, and then it'll pop up a number on there. That number is what you're looking for, and that number is what you want to log in your documentation. Normal levels are going to be 70 to 100, but it's just kind of contingent on the patient. You know, if they just got done eating and they had some big fancy chocolate dessert, you should probably expect their blood sugar to be elevated a little bit. A lot of times diabetics may run abnormally high. Again, these are the situations where you want to communicate with your patient. Hey, your blood sugar is 160, what's normal for you? If they say their normal is 80, well then maybe 160 would lead you to believe there could be something going on depending on what they've eaten, what their activity level's been, everything along those lines. But 70 to 100 is what we're looking for. As the blood sugar gets lower and lower and lower, you're going to start seeing changes in their level of responsiveness to the point that they could be unconscious. It's actually a very, very common EMS call to get called to a diabetic with low blood sugar, and then once you give them sugar and bring that sugar up, everything becomes normal again and they start talking. That's a very common one. If you start getting extremely elevated blood sugars, it should raise some red flags for you. especially if the patient said that their sugars have been running that high for a period of time. It can start doing damage inside of the body, and it is something that they need to get checked out. Last piece of equipment here, and this is kind of a new one, more of an advanced level piece of equipment, but sometimes basics may carry this. There's a couple different ways that we measure it, but it's called capnography, and basically it's measuring the amount of carbon dioxide you exhale from your body, known as end-tidal carbon dioxide. Our normal levels are 35 to 45. And basically this indirectly tells you how well the tissues are using oxygen and performing other physiological features. So it is a very good tool. I can tell you in cardiac arrest, it's kind of our last tool to know if we have a chance at saving a patient. Usually that capnography number will maintain below normal levels, and then right before you get spontaneous pulse from the patient again, you'll start seeing that capnography increase. It's kind of that first indicator that things are correcting themselves in that situation. But from a number of other medical standpoints, it's a very good tool for respiratory emergencies, especially those COPD, emphysema patients, to tell you how much CO they're keeping in their body, to tell you kind of what level of severity that they're in. We'll learn about a lot of this as we go through, but this has become a very good tool in the assessment process as well. The way that we measure with this, there's a couple different ways. So in the airway chapter, we're going to learn about nasal cannulas, which is the oxygen delivery device that goes in your nose. There's basically a little cup underneath of that, so when the patient exhales, the air introduces into this little cup, and then it runs through a sensor and a piece of equipment that you have. Ours is in our cardiac monitor, and then that piece of equipment will determine what the measurement is and display it on the monitor for you. That's for a patient that's spontaneously breathing. However, we can, like I said, still use this in a patient that is not spontaneously breathing, as long as we have an advanced airway in, or you can stick it between the bag valve mask and the actual bag valve. So you would put this little T-piece in there, and then when you squeeze the bag, it's going to push air in. When you let the bag out, that air should still release out of the lungs, and it should still give you a measurement, whether it's an advanced airway or just through the BVM. So that is going to do it for the chapter here. We've learned about a number of different, basically, assessment tools that we utilize to get measurements. Like I said, this is a very important chapter, and this is a very important one that you need to practice. Practice, practice, practice. The more you do these skills, the easier they get. The more you do these skills, the more you understand how they'll dictate what medical emergencies are going on. A lot of these skills are complex in the aspect of mastering them. So practice as much as you possibly can. Go through the rest of the review. A couple more chapters to go in the assessment process. Just remember, like I said, we've gone through, this is now step 3 of the assessment process, but things are going to start overlapping a little bit. So as we start going through the next couple chapters, you're going to see how kind of some of these things work simultaneously at the same time. Lots of information through the assessment chapter. I can't reiterate it enough though. This is the section that you have to master. If you want to be good at everything else you learn in the textbook, you have to be able to perform a good assessment to determine what's going on so you can determine treatment paths. If you have questions, let us know. Otherwise, we'll keep plugging through these.